This is a research review article titled A Balancing Act, Falling versus Aging, published in the Discover Medicine Journal, Volume 1, Article Number 155, published on December 13th, 2024, Open Access, by Tachelle Z. Ting and David S.K. Ting. Abstract. The world population is increasing, and a significant factor behind this is longevity. A fallout of this is the heightening burden on healthcare. In particular, the increasing tendency to fall with age puts a toll on the society and hinders people from enjoying their sunset years. This perspective scrutinizes the underlying causes behind people's deteriorating ability to balance as they age, and presents a review of existing ad hoc mitigation measures. It concludes by shedding some light on the way forward to further the realization of well-balanced, healthier, and successful aging with minimal tendency to fall. Introduction. According to the United Nations Department of Economic and Social Affairs, the size of the age 65-plus population will double in 24 years, that is, increase from 0.8 to 1.6 billion. Living longer is a blessing, but only when we age gracefully. The reality is that the risk of falling along with the number of falls increase with an aging population. The likelihood of a fall is directly related with age, as the effects of aging and its comorbidities accumulate as we age. The falls-aging relationship is complex, as it involves interplays between chronic diseases, functional changes, lessened mobility, decreased balance, decreased muscle strength, cognitive decline, etc. The increase in the tendency to fall does not dawn suddenly at age 65. The progression is evident many years earlier. Data shows that work-related fatalities for working people of 55 years and older are higher than their younger colleagues. Because falls are an obvious drawback of aging, Wang et al. Suggest that successful aging can be inferred from the risk and number of falls. Specifically, the less the risk or number of falls, the more successful or healthy the aging is. Why did they single out falls among so many indicators? This is because a consequence of falling is possible fractures, which can immobilize older persons and significantly heighten healthcare costs, and in the more severe situation, result in premature death. In China, the number of incidents of fracture increased from 12.54 million to 21.27 million from 1990 to 2019. Hip fractures are most prominent for people who are over 60 and are more frequent for females. In the United States, healthcare expenditure for non-fatal falls in 2020 was US $80 billion, compared to US $50 billion for 2015. It is thus clear that to sustain a good living standard tomorrow, we must deal with falls of the aging population today. Falling as we age. The older population falls more often, with frequency of falls increasing with age. According to Kakara et al., 1 in 4 or over 14 million older adults in the United States report falling every year. About 37% of this population required medical treatment, while roughly 3% resulted in death. The frequency of death due to accidental falls for the portion of the Canadian population over 65 years old is plotted in Figure 1. The plots are created based on data compiled by Public Health Agency of Canada and Statistics Canada. The crude rate signifies the total frequency of death due to a fall. It is calculated simply by dividing the total number of fatal falls by the entire population of Canada. The age-standardized rate adjusts the crude rate to minimize or eliminate the influence of age distribution. The near matching of the crude rate and the age-standardized rate implies that most of the deaths are in the 65-plus population. From 2001 to 2007, the number of deaths due to falls increased roughly proportionally with the increasing 65-plus population. This fatality rate surged between 2007 and 2009 before it fell back to the previous rate corresponding to the 65-plus population increase. The good news is that there is a notable drop in the fatalities caused by falls with respect to the increasing 65-plus population from 2014 to 2017, and it remains low since then. Whatever the reasons are behind this drop, the numbers indicate that we can lower the number of deaths and injuries due to falls, ensuring successful aging. Figure 2 shows the situation in the significantly more populated United States of America. The rate of fatalities due to falls for the different groups of seniors from 1999 to 2020 are compiled using data available at the National Center for Health Statistics and USA Facts. We see that the death rate for seniors between age 65 and 74 only increased minimally over the decade. For the 75 to 84 age group, this rate has been rising somewhat more, but still marginally, over the same period. Most disturbingly, there is a significant increase in the mortality rate for seniors 85 years old and older. Thankfully, there is a gleam of hope, that is, the increase in the falls-related fatalities for the 65-plus population trails behind the rise in the senior population. This reveals that whatever the Americans have been doing to mitigate falls in the aging population in recent years are working. More importantly, these positive details along with the Canadian statistics bespeak that there is room for us to do better in furthering successful aging. This paper examines some of the recent studies on this front. Culprits behind falls. Both frequency and severity of falls in the adult population increase with age. The Canadian data, as shown in Figure 1, exhibits an overall approximately proportional increase in death rate with 65-plus population except after 2015. For the United States, Figure 2 depicts that the increase in the rate of fatalities caused by falls has been trailing behind the increase in 65-plus population since 1999. Furthermore, deaths due to falls in the United States are largely occurring in the 85-plus population, but the 85-plus falls-related deaths increase significantly slower than the aging population. While the trend in the United States situation appears better than that in Canada, the absolute numbers in terms of deaths per population are significantly higher in the United States. These results reveal that the falls-age relationship is a complex one. On a positive note, they indicate there is more that can be done in lowering the casualties. The first step toward mitigation is to understand the factors causing falls. Comorbidities. In general, our health deteriorates with age, and seniors who have comorbidities are found to be more likely to fall. Table 1 lists the specific comorbidities that are known to directly influence the likelihood of falls in elderly people. The verdict as to which factor is most influential is a challenging one to reach. This is because many elderly people who fall also suffer from multiple comorbidities. Moreover, cross-comparing among them in a quantitative manner is an impossible task because the severity of each illness is of differing units. This is further complicated by the individualism of the patient when it comes to ailments. On top of that, many factors are interlinked in a complex coupling manner. Nonetheless, the comorbidities are listed in decreasing order in a general sense, based on the state-of-the-art knowledge. Zhao et al. Analyzed and correlated multiple factors influencing fall risk among 1,187 elderly people in a rural setting of China. Their multivariate analysis revealed contributing factors including chronic diseases, multimorbidity, mental health, working status, and access to a general practitioner. In a pilot study involving 26 participants, Kan et al. Found that, among the studied factors, the most prevalent comorbidity was dementia. It is known that with aging, our cognitive function declines, and there is an increasing tendency to develop signs of dementia. Based on a data group of 2,829 older adults, a study by Kim and Kim illustrated that falls correlated strongly with dementia and not cognitive function. The fact that the dementia group had a notably more significant cognitive decline presumably overshadowed the fall cognitive correlation. Visual acuity is also a factor when it comes to falls. Wieczorek et al. Showed that decreased visual acuity is an independent predictor. Older adults who fall have an approximately 20% lower visual acuity. This underscores the importance of regular eye examinations. It is interesting to note that Jin et al. Report that the tendency to fall is linked to poor contrast sensitivity, but not with near or distance visual acuity. Obesity leads to a greater risk of falls as it negatively affects physical health factors such as muscle strength, flexibility, agility, and balance. In addition to obesity, body mass index is directly related to the prevalence of falls. However, obese people are less likely to suffer fractures. Based on over 68,000 Middle Eastern older adults, Al-Sayed Hassan et al. Found a higher percentage of falls in individuals with hypertension, followed by diabetes and then dyslipidemia. Bu et al. Studied over 22,000 elderly intensive care unit patients and found that those who had a history of falls were more prone to experience delirium. On the cause and effect question, there is a possibility that delirium increases the likeliness of falls. Gottsmeister et al. Also included foot conditions, neurological impairments, and postural hypotension to the list of causes. An indirect indicator for comorbidities is hospital visits. This includes those admitted to the hospital because of a fall. Qian et al. Followed 606,392 patients that are over 65 years old following discharge from public hospitals in Hong Kong over a 12-month period. Almost 5% of them experienced falls within 12 months after discharge. Medications can also be a culprit behind falls. O et al. Explored the National Alzheimer's Coordinating Center Uniform Dataset between 2005 and 2023. They found that gabapentin initiation is related to increased odds of falling among those with cognitive impairment. Opioid addiction could follow a surgery. Khalil et al. Followed 15,456 patients after gastrointestinal cancer surgery and found that 1 in 15 patients ended up addicted to an opioid after surgery, leading to increased likelihood to visit a hospital for falls and other problems. Lifestyle and other factors. Table 2 lists lifestyle and other factors that can result in a higher tendency to fall. It is worth noting that elevated blood alcohol concentrations heighten the probability of older people falling. Interestingly, the level of education of a person also has an impact on fall risk. Individuals with low educational attainment seem to have a higher prevalence of falls, and the risk of falls increases in persons with lower education. In another study, Li et al. Disclosed that, of the 2,144 community dwellers they studied, the female group showed no significant relationship between literacy and falls. The male group, on the other hand, demonstrated a robust and significant relationship. Other factors that come with aging are a person's stubbornness for independence, anxiety, and stress that makes mundane tasks risky. Older adults who are wheelchair-bound are also more prone to falls. This is a unique situation that calls for specialized fall prevention interventions. Among the sample of 494 participants in the study conducted by Braindle et al., the risk of fall is found to be not affected noticeably by sex. On the other hand, Faria et al. Found that females have a reduced minimum toe clearance, and this may lead to a higher risk of tripping and falling among older people. Accuracy in one's perception in terms of risk of falling is also a factor. Calvi et al. Categorized 2,222 community-dwelling 60-plus people into 4 groups: 1. Health pessimist, 2. Health optimist, 3. Poor health realist, and 4. Good health realist. Over a 10-year period, 23.5% of the sample experienced an injurious fall. They found health optimists to have the greatest risk of injurious falls, followed by poor health realists, then health pessimists. The best way to counter injurious falls is to be healthy and realistic, that is, good health realists. When and where? L. Delaney et al. Analyzed data from the National Electronic Injury Surveillance System of hospital emergency department visits of older Americans between 2007 and 2017. They found that 2/3 of a total of 537,703 injury-related emergency department visits were fall-related. Of those, 33% were for patients 85 years and older, of which 62.5% of the falls occurred at home. Most falls occur during routine, daily tasks such as cleaning around the house, preparing meals, entering or exiting the home, and even tasks as mundane as opening a window. It is not a task's difficulty, but the aging physical body's worsening balance, range of motion, vision, and slowing reaction. In the analysis performed by Piao et al., it is reported that 62% of the falls occurred indoors. They included discussion on the where, when, and why for the falls. It is interesting to note that Qian et al. Found that among the 4 dimensions of fall risk factors developed by WHO, people with behavioral risk factors, such as the use of a walking aid, have a greater probability of falling as compared with biological, socioeconomic, and environmental factors, such as uneven and/or slippery surfaces, poor lighting, and hazardous meteorological conditions. Muscle strength and cognitive speed are 2 key factors in maintaining one's balance. In a sense, a fall can be equated to a person losing one's balance and the inability to catch oneself. Inevitably, our musculoskeletal, neural, and sensory systems that help us catch ourselves decline as we age. Balancing may be operationalized as the utilizing counter rotation of the hips and/or ankle, readjusting a step, or holding on to an object. Older adults who have experienced a fall in the past have reduced muscle strength compared to those in the same age group without a history of falls. Sufficient rehabbing to regain both central processing speed and muscle torque development speed are required for regaining balancing ability, preventing another fall. Brandel et al. Found that living alone can also increase the odds of falling for community-dwelling people over 60 years old. This may have to do with boredom and/or decreasing alertness, decreasing one's mental and physical reactions with time. Furthermore, living alone may hasten oral frailty. Oral frailty is a decline in oral function along with a deterioration in cognitive and physical functions. Proper nutrition can mitigate oral frailty and fall risk. According to Zhao, oral frailty coexists with the decline in physical, cognitive, and social functions. It leads to decline in physical health and mental health, social withdrawal, lower quality of life, and systemic frailty. Measuring fall tendency. Stepping threshold is tested by measuring how much perturbation one can withstand before needing to take a step. This can predict falls in older people, as the higher the stepping threshold, the less likely a fall will occur. Having a high stepping threshold requires fast central processing of sensory information accompanied by an immediate and appropriate motor response. As central processing speed and muscle torque development speed both affect stepping thresholds, they are areas of interest in preventing falls in the older population. One challenge in studying stepping threshold is the lack of a standard, that is, varying stepping thresholds have been used by different researchers. Foot plantar pressure distribution measurements employed for assessing active back support exoskeleton use can be applied for assessing a person's tendency to fall. Another way to assess fall tendency is to adopt the Kansas University Standing Balance Scale, which has been shown to work across cultures. The walking training approach devised by Mack et al. For rehabilitation therapy is a little more complex and involved, but it is effective for quantifying walking rehabilitation progress. Tarsia et al. Furnished a method for assessing the risk of falling for slippery outdoor conditions. As there are many factors dictating an individual's risk of falling, Murayama et al. Proposed the questionnaire for medical checkup of old as a complement when assessing fall risk. Fall mitigations. As mentioned above, falls may be perceived as our inability to catch ourselves after losing balance. Accordingly, a remedy is to enable effective catching of ourselves when we lose our balance. A better solution is to prevent ourselves from losing our balance in the first place. Staying fit. The best way to prevent falls is to stay fit. Regular exercise, along with appropriate physical, mental, and spiritual nutrition consumption, are keys to staying fit. Many studies confirm this common sense but difficult to practice knowledge. Gauvain et al. Found from a sample of 170 people aged 75 and above, the loss of muscle mass correlates strongly with reduced physical activity. Exercises that focus on balance, strength, and flexibility are most relevant. For example, the Otago exercise program has been proven to improve balance, strength of the lower part of our body, and mobility in older adults. Stair climbing exercises can also improve mobility and posture control in older adults. Undergoing a 10-week multifactorial exercise called Stay Active and Independent for Life has also shown to be effective in reducing fall risk. Chang and Wu combined cognitive and exercise training for older adults with dementia to reduce their risk of falls. Their integration board game and multi-component exercise interventions were found to be effective in mitigating cognitive and physical function decline. Schechter et al. Combined two evidence-based exercise programs in elderly people with incontinence and found them to be effective in simultaneous treatment of incontinence symptoms, balance, and functional status. It is not much of an extrapolation to say that staying fit can mitigate multiple aging-related issues, in addition to the tendency to fall. The in-person delivery of a fall prevention exercise program is more efficacious than an online delivery counterpart. This calls for more senior community centers with regular in-person activities. Along this line, it has been found that low levels of physical exercise correspond to a greater fear of falling. Understandably, the fear of falls typically presents in people who have fallen before. Therefore, the solution approach should involve a multidisciplinary team supplying close monitoring and care, as well as allied health such as physiotherapists, working regularly with physicians and nurses for patients who need extra help with mobility. There is no doubt that exercise helps in mitigating falls. As discussed above, different studies have utilized distinct types and kinds of exercise. Although the varying exercises have proven to be effective in minimizing falls, their effectiveness, as an integrated system involving multiple elements, has not been optimized. Rose concluded that with increasing fall risk, more tailored and progressive exercise programs targeting the physical risk factors are more effective in lowering fall risk. Considering the uniqueness of individuals' health conditions, one size does not fit all. Engineering innovation in personalizing a potent exercise routine for a specific senior is the way forward. Artificial intelligence, including data management and analysis of the existing datasets from around the globe, is called for. A problem-specific regular exercise program is a means to mitigate fall tendency as well as a wide range of comorbidities. Individualized exercise programs that also promote mental and possibly also spiritual health delivered in person seems to be most effective. Helpful habits. Other than adopting the habit of regular exercise, there are some simple habits that we can embrace as we age. A study conducted by Nicholson et al. Confirms that reducing long sitting bouts and maintaining regular physical activity can promote autonomy of seniors. Similarly, Murphy et al. Examined the postural change in seniors. They found that standing from a supine posture entails a much higher risk of falling. Sitting for a few minutes after a supine rest can lower fall tendency significantly. In short, every time we rise from lying down, we should sit up for a minute or two before standing up. Concerning active living, Oliveira et al. Found that coaching interventions can significantly enhance physical activities for older adults. Along with that improvement, their overall well-being also improved. A multi-component approach, including diet, exercise, and social interaction, can prevent loss of mobility in the elderly. Labudek et al. Concluded that behavior change techniques ultimately affect volitional rather than motivational behavior change. Once a person adopts a healthful routine, no further incentive is required to sustain the practice. When good activity habits become routines, they become part of a healthy lifestyle. Walking aids. In general, canes and walkers increase stability by widening the base of support, reducing weight on lower extremities, and giving information to the body in relation to the environment. Liu et al. Found from their gait study that the use of a cane results in a faster velocity with larger steps when walking up a slightly inclined surface. Cerqueira et al. Argued that canes not only provide support but also increase physical activity and lower limb muscle use. In a study by Luz et al., 75% of those who fell were not using their canes, despite having the belief that their canes would help prevent falls. Psychosocial reasons for not using walking aids include forgetting them, feeling old when using the device, and believing they are not needed. Even when older adults fall while using an assistive device such as a cane, they experience fewer and milder injuries. All respondents who required surgery were not using their assistive device at the time of their fall. This message must be conveyed more effectively to the older population. In addition, they should use walking aids even when they are at home. This is because most falls happen in the home when they forfeit the usage of the assistive device because they are in a familiar environment and thinking that they can utilize the walls or furniture instead. Nevertheless, it may be necessary for them to forego using an assistive device when they are showering or sweeping the floor. There is much room for revamping existing bathrooms to be fall-proof, or at least fall-safe. Also, brooms and mops can be integrated into walkers to allow seniors to accomplish regular contributions such as keeping their living quarters clean. Encouraging those who can benefit from using a walking aid is the key. Equally important is education and training to utilize the device properly. Incorrect usage not only does not decrease, but may increase the tendency to fall. This is especially true in the presence of obstructing furniture. Therefore, it is critical for assistive device users to be properly trained to use their assistive device. At the same time, they should not forfeit regular lower body strengthening exercises and lean too much into canes and walkers. Cane users are suggested to increase ankle plantar flexion in the initial swing phase to avoid deteriorating gait performance because of overly relying on the cane. One prerequisite to this is to ensure that the right cane length is selected for the individual. Improper cane length can adversely affect the user's postural stability. From their literature review on the usability of rollators, based on 45 publications, Schmucker et al. Highlight the lack of publications on the usability of rollators and emphasize the need for user-centered participatory research. They further advise potential users to insist on product instruction and adaptation and participate in the rollator training program. Nickerson et al. Video captured the falling of older adults in long-term care who were using rollators and two-wheeled walkers. Most falls took place sideways when the users were turning, followed by falling backwards during weight transfer. Poor maneuverability, lateral stability, and wheel velocity control contributed to the falls. This calls for better design of rollators and two-wheeled walkers. Accessible and elder-friendly architectures. Typical home architecture and design do not take the special needs of the geriatric population into consideration. For example, high window latches make it challenging for seniors to open and close windows, and narrow doorways make it difficult to move walkers into bedrooms and bathrooms. A welcoming design for all trend is coming, where building regulations will include a detailed approach to the mobility needs of older and disabled people. As falls in hospital are of great concern and extremely common, instead of working to prevent them, some experts have suggested preventing injuries from falls by implementing a shock-absorbing flooring. Much research must be done in this area to ensure the shock-absorbing flooring does not lead to more falls when compared to normal flooring. But even if more falls occur on the shock-absorbing flooring, this could still be a viable option if less injuries occur from the shock-absorbing flooring falls. Additional preventive measures. Ideally, we want to keep vulnerable patients out of the hospital after they have a fall, but in nearly half of the cases, hospitalization is necessary, such as needing imaging and/or surgery. As conveyed above, hospitalization leads to an increase in the risk of falls. Being in an unfamiliar environment with many obstacles may be one reason for this. Furthermore, due to the busyness and noise in a typical hospital setting, the lack of good sleep may also contribute to the tendency to fall. Hospital visits, including transfers, can be minimized if patients have the proper post-fall care, such as close monitoring and a planned follow-up appointment for further evaluation as needed. Educating the patient and staff also reduces falls in hospitals. For frail patients with dementia, comprehensive and inclusive research in hospital environments is needed. It is important to recognize that treating and preventing falls is not a one-dimensional task in the hospital, but an issue that requires collaboration between general practitioners, outpatient departments, emergency departments, and nursing and geriatric organizations. Innovative fall prevention engineering. There is much room to further conventional canes and walkers by tapping into the artificial intelligence technology. Normal canes assist in daily physical movement as they provide extra stability. A smart robotic cane can recognize the user's natural gait and predict the intended movement. With these abilities, a robotic cane can help supporting the user's gait without restricting movement. Based on a comprehensive literature review, however, Sam et al. Concluded that robot-assisted interventions for fall prevention are in their infancy. Among others, Jane and Burke concluded that technologies based on artificial intelligence might be the future of falls prevention in the post-acute care, long-term care, and assisted living facilities. Mohan et al. Asserted that artificial intelligence and internal of things will be the best solution for fall prevention in older adults. Artificial intelligence can also be employed to monitor other factors such as the nutrition and medications taken by a person. Complemented by efficacious body sensors with real-time feedback that can activate the respective nerves and muscles, an intelligent, individualized computer system can avert an impending fall. The artificial intelligence can also identify objects or building structures that should be modified to eliminate trip hazards. Personalized individual robots in the form of compression and ankle socks or bodysuits appear tangible in the not-too-distant future. An interactive robotic bodysuit that adjusts the ankle, knee, and other muscles and/or movements to stabilize the wearer may be the ultimate solution. These fall prevention suits can include shoes such as those reported by Simsik et al. There remains much research and development on this front. Among others, these body armors must be light and comfortable to wear, easy to wash, and affordable for all. In the near term, advancements in assistive devices such as canes and walkers, sensors, cushioned floors, etc. must continue. Further work on fall detection and fall risk assessment is a prerequisite to improve these new technologies. Wearable, inertial, and other sensors, such as those studied by Silva et al., are essential. There are many commercial products such as hip pads and inflatable bodysuits. Some of these apparently bizarre gadgets work quite effectively. For example, providing proper hip pads can minimize damage from a fall. Bulkiness is one of the remaining issues to overcome. Some of these physical protective features can complement the battery-powered interactive nerve and muscle-activating sleeves proposed above. Concluding remarks. The risk of falling increases with age and is attributed to numerous factors, many of which are intricately coupled. Research on using artificial intelligence in fall detection and prevention will likely increase in the next few years. It may also be employed to scrutinize the increasing amount of data collected for gait and other assessments. In the short term, hastened effects in furthering fall preventive canes, walkers, and indoor architecture are needed. However, it is important to keep in mind that a significant portion of the aging population is in developing countries where these technologies are not readily available. According to WHO, among the 684,000 individuals who die from falls each year, over 80% are in low and middle-income countries. The underlying factors can be broadly categorized as human musculoskeletal, neural, and sensory systems. As such, the best remedy is to exercise regularly, keeping our muscles strong and our mind sharp. There are quite a few forms of rehabilitation exercise. The most suitable exercise may be selected based on the specific challenge faced by the individual. Active living encompassing continuous engagement with community can prevent adverse psychological mentality. Communities should be engineered to include age-friendly amenities, walkways, grocery stores, and healthcare and shopping centers. It is time for every person to be able to participate in their communities regardless of age. Data availability. Data is provided within the manuscript or supplementary information files. The sources where original data were obtained are explicitly cited and the references are provided.